Our first speaker today is Dr. Jane Wilcox. Dr. Wilcox is the chief of the section of heart failure treatment and recovery at Northwestern University Feinberg School of Medicine. She's also the associate director of the T1 Center for Cardiovascular Therapeutics in the Bloom Cardiovascular Institute. She's a board certified in advanced heart failure and transplant. Dr. Wilcox is also the director of the Myocardial Recovery Clinic for patients with heart failure with recovered ejection fraction. This morning, she's going to be speaking with us on the topic of arrhythmogenic cardiomyopathies and genetics testing.
Well, thank you so kindly. It's a pleasure to be here. And these are our objectives. So for the next 15 minutes, we're going to go over all of arrhythmogenic cardiomyopathy and genetic testing. It's going to be great. But in all seriousness, I'm going to give a sort of a case-based approach with some high-level, I think, key takeaways regarding arrhythmogenic cardiomyopathy, inherited cardiomyopathies that'll be important for your clinical practice, as well as the role of genetic testing. So let's start with genetic testing, and this is just to set the stage. When we think about a genetic variant, the more rare a variant is, here on the x-axis, the more rare variant something is, the larger phenotypic effect it is. And we call these private variants, and they tend to run in families. As we move along the allele frequency in the population, common alleles have a small effect on the phenotype that a patient or a family member might express. And multiple factors drive why we do genetic testing in our clinical practice. Obviously, patients need a diagnosis. It alters management. We're going to talk about ICD indication in some of these patients, as well as family members who might be at risk. There are three possibilities when we get a genetic testing result. And before reviewing that, I'm going to make the key takeaway that genetic counseling here is critical because the results and their implications can be complex. You need to advise family members before they're getting testing about the risk of not being able to get life insurance with a positive result. And so the comment was made earlier about the lack of heart failure cardiologists, the lack of genetic counselors and genetic cardiovascular specialists is even more dramatic. And so genetic counseling goes hand in hand with genetic testing. But on the bottom, you see the spectrum where you have a benign variant or a pathogenic variant. Pathogenic, where there's strong evidence that exists that the variant can cause disease. Benign, this is observed at a high frequency in the general population, unlikely to be a disease-causing variant. And then the dreaded VUS, the variant of uncertain significance. This is where the patient the variant is very rare, but we've not maybe seen it before. And we don't know whether it contributes to disease. But importantly, a variant of uncertain significance is not a negative result. And equally as importantly, an absence of a pathogenic variant does not rule out a genetic cause. And patients still need, and patients and their family members rather, still need clinical screening. So in cardiomyopathy, who should be tested? All patients with HCM, all patients with left ventricular non-compaction, all patients with arrhythmogenic cardiomyopathy, whether it's ARVC, left dominant phenotype, or biventricular phenotype. And I will argue most patients with non-ischemic dilated cardiomyopathy. And these are patients that we used to call idiopathic, or maybe they had a virus. We're finding more and more that the genetic predisposition to develop cardiomyopathy and the cause of cardiomyopathy is becoming more and more apparent that is a genetic association. And so in patients with DCM who are less than, I would say, 60 years of age, genetic testing should be offered to these patients. My other disclosure is I work closely with Wilson Tang in the DCM precision medicine study. And so we're very keen to testing patients and their family members. So key points to summarize this: genetics professional who is skilled at obtaining reliable family history and identifying those at risk is incredibly important. Specific questions should be asked for patients to identify possible affected relatives. Was there a car accident on a sunny day? Did someone drown? Was there someone with a pacemaker, neuromuscular disease, anyone in a wheelchair, died early at a sudden age? These types of questions, when you're interviewing patients, can sort of help patients find the file that may clue you in to a genetic disease. And finally, primary clinical data should be reviewed. This is where I want to see the echo. If it was called normal, that's fine, but I actually want to see the echo, especially in those first-degree family members. All right. So let's move to important genotype-phenotype considerations. And this may be a busy slide, but this is for your reference here. This is work that Ray Hirschberger and I put together to sort of, this is the cell, right? So you've got the sarcomere in the middle, where most common you see genetic mutations in the sarcomere, like titin, muscular dystrophies in the top left. This is Duchenne's muscular dystrophy, as well as Becker's muscular dystrophy. Moving over to the right, can I do this? Oh, no, I can't. It's the mouse. Okay, maybe not. Arrhythmogenic cardiomyopathies, which we'll go over some of those important genes to know. And then all the way down to conduction abnormalities, nuclear envelope proteins like lamin, as well as LVNC. Importantly, a mutation into FASN can cause Barth syndrome. So this is sort of the whole look of the cell and how any variant in one of these proteins can lead to a specific phenotype, but there is a lot of overlap when we are taking care of these patients as well. So let's just go over a case. This is a case that I saw, I actually saw him in clinic yesterday in follow-up. I've been following him for 10 years. 51-year-old man with atypical chest pain, lightheadedness. His echo came in, his EF is 40% and prominent trabeculations. His cardiac MRI solidifies the diagnosis of LVNC with non-compacted ratio to compacted ratio of greater than 2.3 and more than 3 segments. You can see the testing here. The clinical management of left ventricular non-compaction cardiomyopathy is really, again, 4 pillars. And so I'm meeting with the patient, I'm talking about the role of GDMT, specifically beta blockade and ARNI compound. Arrhythmia monitoring, we know that these patients are at higher risk for arrhythmias, and we'll go over some of the genetics. We had a discussion about anticoagulation, especially when the ejection fraction is less than 40%. Guidelines recommend that we start the patient on anticoagulation and then refer for genetic testing. So I started him on meds and warfarin at the time. It was 10 years ago. And I was out shopping and I got paged that the patient had self-terminated VT on his event monitor, and immediately called the patient and we placed an ICD. What did his genetics show? He had 2 variants that I was concerned about. The first was a variant in titin, a likely pathogenic variant, and the second was a variant in RBM20. And this was called a variant of uncertain significance. Let's go over titin. So titin is the largest gene in the sarcomere. This was first identified by Cricket Seidman's lab. It was sequenced. It was a big deal when we found out that titin was the most common cause of dilated cardiomyopathy and peripartum cardiomyopathy that was genetically mediated. Truncating variants now account for about a fifth of all of dilated cardiomyopathy. There are 4 domains listed here: the Z band, the I band, the A band, and the M line. I won't go over this in detail, but there are different isoforms of titin. There's the N2B and N2B and N2A isoforms, and relative splicing of these isoforms can affect the phenotype. The majority of variants that are pathogenic exist in the A band and account for the majority of DCM, and they can be seen in DCM, LVNC, as well as HCM. And up to 20% of our patients with a pathogenic titin actually present with early atrial arrhythmias before the onset of dilated cardiomyopathy. And so indeed, our patient had a titin mutation. But why did he have sustained VT? I don't typically think of this as a really arrhythmogenic mutation. The RBM20 is what affects splicing sites. And this is a very arrhythmogenic mutation traditionally associated with ARVC. So this case made sense in the context of his genetic mutations, his phenotypic expression. Here are some pearls here. It's autosomal dominant. There can be acquired versions of LVNC. Important to note here, as well as phenocopies. And for those of us in transplantation, we do know that LVNC has worse outcomes overall compared to dilated cardiomyopathy with regard to AFib, thromboembolism, and these patients need to be followed closely because they often progress to need heart transplant and advanced therapies. All right, let's go over a 65-year-old man who was sent to me by Dr. McCarthy, who was mentioned earlier here. We had our 20th anniversary at the Bloom Cardiovascular Institute. And this was about 8 years ago. Pat called me up and said, I don't think I need to operate on this guy. But he had a 10-year history of paroxysmal AFib. He was found to have new atrial flutter and had dyspnea on exertion. He was being seen in Indiana, and that angiogram showed an LAD lesion of 70%. And he was sent to us to receive a maze operation and a 1-vessel CABG. We did a stress MRI at the time that was negative for infarct, ischemia, and there was no late gadolinium enhancement. So CAD was not the primary driver. The AFib, we're not sure about that, so we sent to me. I started him on GDMT, and I was suspicious for a genetic cardiomyopathy because he was relatively healthy in his 60s and had this long-standing early AFib. He also had sinus bradycardia, as well as a possible sudden cardiac death in a maternal uncle. And so I sent a GeneDx panel. I also sent him to EP. At the time, ablation wasn't salvation, I'll say, when we take care of our heart failure patients. So he was cardioverted, started on GDMT, eventually had an ablation, and his EF returned to normal. This is his presenting EKG. You can see here relatively low voltage and some of the limb leads, a left bundle with flutter. Post ECG, he has a profound PR delay, first degree AV block with a left bundle. And indeed, the genetic testing showed a mutation in lamin. So lamin cardiomyopathy is, again, a key point where this is really changing medical management for our patient. Lamins are ubiquitous proteins that exist. They're nuclear envelope proteins. They're located in that internuclear membrane, and they provide structure and stability. There's an autosomal dominant pattern of inheritance, and there's often early disease conduction and a high risk of VT and sudden cardiac death. And so indeed, this patient had a defibrillator that was placed based on guideline recommendations. Now, male sex, EF less than 45%, a lamin missense mutation. These are patients at high risk and should be considered for ICD prevention of sudden cardiac death. All right, the classic sort of arrhythmogenic cardiomyopathy is ARVC. This is where you have myocardial necrosis followed by fibrous fatty replacement. The classic syndrome is Naxos syndrome from the island of Greece, where you have woolly hair, palmar erythema, and keratomas. The average age of presentation is 36 years old. It's more common in men, and there are 4 phases of the disease. First was sort of the scariest part, right? The asymptomatic disease, but increased risk of cardiac death, leading all the way down to biventricular heart failure and where arrhythmias may be less common. This is not meant for you to go over in detail, but these are the diagnostic criteria that have been updated by the Europeans in 2024. And the take-home point here is that we're using cardiac imaging, specifically cardiac MRI, to increase the sensitivity of our diagnosis. You can see here in the top panel, this is LGE with a myocardial ring-like fibrosis that is now pathognomonic for ALVC, or arrhythmogenic cardiomyopathy, left predominant phenotype. As well as on the bottom, you see LGE on the right ventricular diaphragmatic free wall, which is pathognomonic for ARVC. So in addition to a careful family history, as well as monitoring for arrhythmias, imaging is really the cornerstone of the diagnosis. The management of ARVC is a 5-legged stool, again, making sure that diagnosis is nailed, and then predicting the risk of sustained ventricular arrhythmias to guide the decision about ICD. Minimizing ICD therapies, catheter ablation really doesn't improve survival, but can improve symptoms. And then preventing disease progression by reducing high-intensity competitive sports and screening of family members. The genetics are listed here. Most of ARVC is really a problem of the desmosomes. This is a primarily autosomal dominant. Over half of them are desmosomal genes. PKP2 or TMEM43 are rare and highly lethal. In those scenarios, an ICD should be considered. And our last case, in the last minute, a 41-year-old man with dilated cardiomyopathy presented with VT storm. And we did a PET sarcoid CT. We thought, we're missing a bunch of sarcoid. It was positive. It lit up like a Christmas tree. We started him on steroids, and then we did genetic testing. And lo and behold, we saw a desmoplakin mutation that was a pathogenic variant. And we're seeing this now, this overlap between inflammatory cardiomyopathies, sarcoid myocarditis, and pathogenic variants in desmogliin here, as reported in Circ Genomic and Precision Medicine, desmoplakin by our colleagues at University of Chicago, and as well as the genetic architecture here. So DCM or ACM genetic variants were present in up to 8% of those with acute myocarditis. So when you have red flags in the clinical history, like a prior history of myocarditis, a family history of dilated cardiomyopathy, obviously, but low voltage on the ECG, as well as T-wave inversions, obviously a patient has non-sustained VT, or they have an echo that is not that dilated, but there's hypokinesis with normal dimensions, and that ring-like, subepicardial ring-like late gadolinium enhancement. These are all red flags that we should be thinking about arrhythmogenic cardiomyopathy. And my last slide here, if you have a pathogenic variant, this is where we do cascade testing in first-degree family members. These genes is really where you have the discussion with your electrophysiology colleagues about the risk of sudden cardiac death and placing that ICD in certain patients. No pathogenic variant does not exclude the family members from being screened clinically with echocardiograms and an exam. And if the family history is positive, this is where we're thinking about whole genome sequencing and research. And this is where I think the field is burgeoning. So in summary, gene mutations in this sarcomere cytoplasm, remember that cell I showed you earlier, the nuclear envelope, including desmosomes, all can cause cardiomyopathy. There is a phenotypic overlap. These same genes can be in different family members of the same family and have different phenotypic expressions. If there's early onset AFib or conduction abnormality, this is where you need to think about lamin, filament C, or others, because pathogenic mutations can alter our management for ICD, and a negative result does not rule out a genetic contribution. All right, thank you so much.
I'd like to welcome Dr. Ayman Hussain, who is presenting in place of Dr. Kanj. So Dr. Hussain is the Director of Electrophysiology Research at the Cleveland Clinic and also co-director at the Center of Atrial Fibrillation. His topic today is on LAA and controversies in anticoagulation.
Thank you. Good morning, everyone. So over the coming 15 minutes, I'm hoping to provide an up-to-date review of strategies of stroke prevention, cover some of the controversies related to this topic in atrial fibrillation patients, and provide you with some updates about ongoing research. We know that AFib is very common in heart failure and is associated with increased risk of morbidity and mortality. When it comes down to managing AFib, the 4 pillars of AFib management are rate control, rhythm control, stroke prevention, and risk factor modification. Rhythm control is very important in heart failure patients, but arguably stroke prevention is the most important aspect of AFib management. That is because AFib increases the risk of stroke by 5-folds, and we know that AFib-related stroke is the most devastating of all strokes because it increases the risk of mortality, morbidity, and disability versus non-AFib related strokes. So how do we manage this? CHA2DS2-VASc score is the most validated score to guide our decision making in terms of anticoagulation and stroke prevention. It has its limitations, but this is the best tool that we have today. Currently, for patients with a CHA2DS2-VASc score of 2 or more, we have indications for anticoagulation for stroke prevention. It is reasonable to anticoagulate patients with CHA2DS2-VASc of 1, and that has been our practice for the most part, whereas patients with a CHA2DS2-VASc of 0 don't necessarily need anticoagulation for the purpose of stroke prevention in AFib. What are the options that are available to us today? Obviously, DOACs, and these have become the most up-to-date kind of medications for stroke prevention, and they are almost standard of care in most patients, and for the most part have replaced warfarin. How about non-medical ways to prevent stroke and atrial fibrillation? Left atrial appendage exclusion, either surgically or via percutaneous devices, have been used more and more frequently over the past 10 years, and I'll go over the evidence that supports its usage. A quick note here is that platelets or antiplatelets alone are not enough for stroke prevention purposes in patients with atrial fibrillation, neither aspirin, Plavix, or dual antiplatelet therapy, and when one may argue that the combination of dual antiplatelet can increase the risk of bleeding more than it gives a benefit in terms of stroke prevention. During this talk also, I will cover some of the newer oral anticoagulants, that is the factor XI inhibitors, and ongoing research about that. Is the decision to anticoagulate usually simple? I mean, in most patients, possibly, but we always have to take into account the bleeding risk. All currently available anticoagulants come with bleeding risk, and we have to weigh the risks and benefits of anticoagulation in these patients. As I mentioned earlier, DOACs have, for the most part, replaced warfarin in clinical practice, largely because they were shown to be non-inferior in terms of prevention of ischemic strokes, but much better in terms of reducing the risk of hemorrhagic stroke with a 50% relative risk reduction compared to Coumadin. They can also decrease the risk of death by 10% compared to Coumadin, and the risk of major bleeding by 14% compared to Coumadin. When we look at the types of bleeding events, all of this comes with the cost of a slightly higher GI bleeding risk versus Coumadin, but overall, the major bleeding risk is still less. That's why, and these are data from a meta-analysis looking at all the major clinical trials on DOACs. We have shifted for the most part to using DOACs over warfarin in patients who have non-valvular atrial fibrillation. So we know these medications are great, but there are problems. There are issues with this. What are the issues? They are underprescribed. Not only with DOACs, all oral anticoagulants are underprescribed in clinical practice. As a matter of fact, there are studies showing that only 40% of patients who qualify for anticoagulation for stroke prevention in atrial fibrillation are getting oral anticoagulation. That's a big problem. Stroke risk, residual stroke risks. Why do we have residual stroke risks despite being on these medications? These medications, there are issues with compliance, interruption, underdosing. There is a big issue that is nationwide in terms of off-label use of or dosing of anticoagulation. Just because somebody is 85, we decide to reduce, not us, some care provider decides to reduce the risk of, for example, Eliquis, but they do not necessarily meet indications for dose reduction. Somebody decides to reduce it because their risk at fall. But, again, we may be exposing patients to the bleeding risk, but without necessarily getting the stroke prevention benefit with off-label dosing. But there are issues with cost as well. Even in those clinical trials that were published on these medications, there is a residual risk of stroke, up to 2% per year. There's also bleeding risk with these medications, and I'll cover that later in details about the mechanisms. So there is about 2 to 5% per year bleeding risk with these medications. So are these medications not good? No, they are needed. And we know that if of all the interventions in AFib, I know that there was some more recent evidence regarding ablation in patients with heart failure and showing survival benefit. But before that, the main therapy that showed improved mortality in patients with atrial fibrillation was anticoagulation for stroke prevention. Anything else and everything else was about improving quality of life, okay? So it is important to prevent stroke. But these issues with anticoagulants led to the thoughts about left atrial appendage occlusion, meaning we know that 90% of these clots in AFib originate from the left atrial appendage. So the thought process here What if we close that area? What if we seal it off and maybe provide a mechanical way to prevent stroke or thromboembolism in patients with atrial fibrillation? Can we achieve the same stroke prevention benefit without necessarily the ongoing risk of bleeding and compliance? Meaning we put a watchman or an amulet or close the appendage. If we were to close the appendage, then we are not relying on the patients in terms of compliance. There are not issues related to long-term cost and bleeding risks and things like that. So over the past 10, 15 years or 20 years, there's been a lot of interest in terms of developing tools to close the left atrial appendage. The most commonly used devices now are the Watchman Flex, the Watchman Flex Pro, and Amulet is also being used. And we've seen over time that closing the appendage compared to warfarin results in a 55% relative risk reduction in disabling strokes. It also reduces bleeding risk by 72% compared to Coumadin, and 27% risk of or reduction of risk in all-cause mortality compared to Coumadin. These points are driven primarily by lower risk of hemorrhagic stroke and lower risk of major bleeding events. Real-time data, real-world data on this was from the SORPAS registry, which included up to 67,000 patients, with 18,000 of those followed for up to 1 year. And it showed that the implant success rate is very high in real-world practice, up to 98%. Very, very, very low complication rate at 0.5%, and with benefit in terms of stroke prevention. That's why these devices are being more and more used. But as of today, and the evidence in terms of using them and supporting their use is in patients who have contraindications to be on oral anticoagulation for the long term, patients in whom we are concerned about bleeding risk, patients who already had bleeding events. So in our practice, it's been primarily about those patients who are high risk, okay? All the data about appendage closure have led to the more recent guidelines, updating recommendations and giving a higher level of recommendations for appendage closure, percutaneous closure, in patients who are contraindicated for long-term oral anticoagulation. Are there any more patients out there who are going to benefit from this? We know that these devices work. We know that they are safe, high success rate with implant, without the bleeding risk in the long term. Okay, can we expand the indications? So there are ongoing trials on this, and I'll share with you the results of the option trial. And here I can tell you that there are at least 2 ongoing trials, the Champion and Catalyst, looking at Watchman and Amulet in patient versus anticoagulation in patients who can actually be on long-term oral anticoagulation. So these were not patients who are contraindicated for long-term oral anticoagulation. How about combining therapies? If I put a Watchman, but somebody can still be on anticoagulation, do I put a Watchman and keep them on anticoagulation? We know that there might be some atrial myopathy component to stroke risk. We know that there might be things beyond the left atrial appendage that could benefit from anticoagulation. As a matter of fact, there was the LEOS-3 trial, which showed benefit of combined therapy. LEOS-3 was surgical closure of the left atrial appendage with a clip. And LEOS-3 showed that the best results in terms of stroke benefit or stroke prevention was in patients who had a clip on the appendage and remained on anticoagulation versus those who were on anticoagulation alone. Maybe a combination therapy can provide the ultimate benefit in terms of stroke prevention. And this is what LEOS-4 will be investigating. LEOS-4 will be randomizing a large number of patients to oral anticoagulant with Watchman Flex versus oral anticoagulation alone. And we're excited about being part of this, and hopefully we'll see the results in a few years. Another controversial issue is anticoagulation after a successful AFib ablation. So the question comes down to this: does AFib ablation decrease the risk of stroke by decreasing AFib burden? The answer is maybe, and we don't know. I mean, there is not robust evidence so far that would support discontinuation of oral anticoagulation after a successful ablation. That's why the guidelines, as of today, still recommend to go by the CHA2DS2-VASc score to decide on long-term anticoagulation in these patients. Meaning if I ablate someone and they come back and they haven't had a single AFib in over 2 years, but their CHA2DS2-VASc score is 4, regardless of whether they had AFib recurrence or not, they need to be on oral anticoagulation. Is there a benefit of left atrial appendage closure post-ablation? Okay, and that's what option addressed, and I'll cover that. There are also some medical trials looking at oral anticoagulation versus aspirin after successful ablation. One of them was OCEAN. The OCEAN trial was comparing rivaroxaban versus aspirin in patients who made it to 1 year after ablation and remained arrhythmia-free, who had successful ablation. We know that this will be completed soon, but enrollment was stopped at 1,284 patients, so it was cut short due to the DSMB, the Data Safety and Monitoring Board recommendation to stop the trial. So we'll see what that eventually shows. In terms of option, Dr. Wozni, who's here with us today, was the leader of this, and it was published in the New England Journal of Medicine earlier this year. Option investigated whether or not a Watchman Flex implant is reasonable alternative to oral anticoagulation after AFib ablation. So it randomized patients who had prior ablation or undergoing ablation to Watchman plus short-term anticoagulation versus oral anticoagulation. The main safety endpoint showed superiority in terms of safety, in terms of major bleeding and non-procedural bleeding and clinically relevant non-major bleeding at 36 months. The non-inferiority endpoint of major bleeding, including procedural bleeding, was non-inferior between the two modalities or the two arms. And the primary efficacy endpoint, which was a composite of death from any cause, stroke or systemic embolism, was non-inferior between the two. In other words, in patients who had undergone an ablation, implanting a Watchman was good in terms of stroke prevention in the long term without necessarily exposing patients to the bleeding risk, which is great. So what's next? The factor 11 inhibitors are being investigated, and here this is a trip back to med school with the intrinsic pathway, the extrinsic pathway. We know that the intrinsic pathway is involved in thrombosis. The extrinsic pathway is involved in hemostasis. The currently available anticoagulants assess or address the common pathway. Apixaban, rivaroxaban, or edoxaban are factor 10 inhibitors. Dabigatran is a direct thrombin inhibitor. So in theory, because they are achieving thrombosis prevention, they are doing so by also increasing the risk of bleeding because they are also affecting the body's ability to achieve hemostasis in response to vessel injury. Whereas if we address something that is only on the intrinsic pathway, such as factor 11, can we decrease production of thrombin and improve thrombosis risk without affecting the bleeding risk, because that way we wouldn't be affected the intrinsic or the extrinsic pathway of hemostasis. So theoretically, this is sound. But what did the data show us so far? The first one here to be tested was esondixan, and this was compared to Eliquis in the Pacific AFib study. This was a phase 2 study that showed that a direct, factor 11 inhibitor resulted in less bleeding compared to Eliquis. That's great. We showed safety. So in phase 3, it failed to show efficacy. Okay? So better safety, but lack of effectiveness. Is this a dosing problem or a class effect? We don't know the answer to that. So more research is being done. This is on abilisumab, which is a monoclonal antibody for factor 11. The phase 2 Azalea trial showed that there is much less risk of bleeding with this medication versus rivaroxaban. As a matter of fact, the study was stopped early, secondary to the reduction in bleeding with this versus rivaroxaban. And if you can take a closer look here, the bleeding risk, the GI bleeding risk, was almost non-existent with this medicine. And if you remember, most of the GI bleeding trouble with traditional oral anticoagulation has been GI bleed, most of the major bleeding events. So the idea here is that if we achieve stroke prevention with these kind of medicine without increasing the risk of bleeding, that would be a winner. But that's what the phase 3 trial is investigating. Importantly, and this cannot be emphasized enough, managing risk factors, losing weight, treating hypertension, treating diabetes, and preventing AFib. Maybe that would be the best way to prevent stroke and atrial fibrillation. So I'll summarize here. Stroke prevention is one of the pillars of AFib therapy. Oral anticoagulation with DOACs remains, as of today, the primary and preferred choice, but currently indicated, left atrial appendage occlusion is currently indicated in patients who are not candidate for long-term oral anticoagulation therapy. And there are ongoing clinical trials that will potentially expand the indications for left atrial appendage closure. Newer anticoagulants show promise for safety, but we're still awaiting results regarding efficacy. And most importantly, addressing upstream therapies and risk factor modification could be the most cost-effective strategy for stroke prevention. And with that, I thank you so much.
Theme of atrial fibrillation. Next up, we would like to welcome Dr. Wozni. Dr. Wozni is the section head of electrophysiology at the Cleveland Clinic. He directs the outpatient EP department and co-directs the Center for Ventricular Arrhythmia and the Center for Atrial Fibrillation. Today, his presentation is on AF ablation and the pulsed field era.
All right, good morning, everyone, and thank you, Dr. Best, for inviting me to this. So the title of my talk on your agenda is AFib ablation in the pulse field era. Who knows about pulse field ablation? Hands? Not a lot. Okay, good. So we have something here. So I'll give you a summary of the talk right now. It's all about pulse field ablation now. AFib ablation is just pulse field ablation for AFib. So that's the summary of the whole 15 minutes. You can take a break now. But how does it pertain to heart failure? So this is the first study actually to show that atrial fibrillation ablation decreases mortality. And it was done in a group of patients with heart failure. So this is called the CASTLE-AF study. It was published in New England Journal of Medicine in 2018. You can see it there. And this was really the first study that showed that AFib ablation improves mortality. Again, can I have the timer started, please? I know I finished my talk already, but so that I can stay on time. It's not on, but anyway, all right, there we go. Thank you. So yeah, this was a very important study. Again, because it showed that in patients who have heart failure, ablation decreases mortality. It was followed by another study recently published, I didn't put it here, in the CASTLE-AF heart transplant study, which showed that ablation in those much sicker patients can delay time to LVADs and transplants. So that's the summary of that study. Now, those other patients, though, are much more difficult to manage because they're in a lot of heart failure, and it's actually hard to ablate those patients. So how does PFA relate to this? Well, this was all done with radiofrequency and cryo, mostly radiofrequency. Radiofrequency means heat, and also it means that we have to cool the catheter, so we have to give them a lot of volume. So that was the trick in those. But now with pulse field ablation, there is no irrigation. So there's no volume that's given to the patient. So that's why it's actually an attractive therapy for AFib ablation in heart failure patients. So a quick review here on radiofrequency and cryo. Radiofrequency is heat. Basically, it depends on resistive heating and conductive heating. I'm not going to go into the physics of it, but basically it heats the tissue in a way that is most of the time not controlled. And sometimes we cannot predict where it will go, so it can cause damage to collateral structures such as the esophagus. Same thing with the cryoablation. And that's why we needed something that's safer. And this is where we come to pulse field ablation. So what is pulse field ablation? On the left-hand side, you'll see that it's basically a train of pulses, DC current, that has a pulse width, a pulse duration, a burst. Anyway, each company has a different recipe, but what it does, it basically causes electroporation of the membrane, cell membrane. Water rushes into the cell and basically causes cell death in that way. And the good news about it is that it's not heating and it's not freezing. So then there's no collateral damage to the esophagus, phrenic nerve, or even the pulmonary veins. So there's no pulmonary vein stenosis, no esophageal injury, and no phrenic nerve paralysis. I'm not going to go through all of this, but this is basically the shapes and different types of catheters that are available right now for us to use for pulse field ablation. Quickly, just here to show that the efficacy, the next few slides, will show you that the efficacy is basically the same as previous with radio frequency and cryo. So what's pushing this is actually it's a lot faster. No infusion of normal saline, and also the safety. So it's really driven by safety. Now, I don't know if any of you have worried about or treated esophageal injury, for example. That's a nightmare for everybody, for the patient, first and foremost, but also for the team taking care of the patient. So this was adopted overnight. I remember we're having a lot of discussions where, what do you think the adoption rate is going to be like? And people were saying 50%, 60%. It was 100% on day one, mostly because we didn't want to hear or even have to think about injury to the esophagus, to the phrenic nerve, or the pulmonary veins. Again, the efficacy is the same, but the safety is much better. All right, so I'll skip this. It's just, again, there are different types, and every company has to do their own pivotal FDA approval study before getting FDA approval. So that's why you'll see a lot of studies of these, because each company has to do their own study, because each company also has their own secret recipe, supposedly, for pulse field ablation. But again, the good news is that the efficacy is good. Here, this one, on the paroxysmal side, this is one type of catheter. It's called the Pulse Select. In paroxysmal atrial fibrillation, it was 66% versus 55% in persistent patients. Our results here at the clinic are a lot better. On the paroxysmal side, it's more to 85%, and 70 to 75% on the persistent. This is from Europe. It's called the Manifest Registry. And basically, it shows the same thing. Basically, paroxysmal is about 80% and persistent around 60% using a different system called the FARAPulse system from Boston Scientific. Again, what's driving most of the adoption is really the quick procedures and also with less complications. So this is the study that got FDA approval for the FARAPulse system. It's called the ADVENT study. And basically, it was a multi-center prospective, single-blind, non-inferiority study, and was comparing the FARAPulse system, that thing that looks like a flower. It's called the pentaspline catheter. That's how we call it, versus radiofrequency and cryo. It's called the thermal group. And these were the results. And basically, no difference in efficacy. You can see that the pulse field and the thermal ablation lines basically are right on top of each other. So very good results in terms of efficacy. Serious events, if you look closely on this chart here on this table, that there was one death, and it was in the pulse field ablation. So I just told you it was so safe. And the only death that happened in the study was actually in the PFA. So how could that be? Well, it's still operator dependent. You still have to be able to move catheters around in the left atrium safely. And you should be able to, if something bad happens, rescue the patient. So this is a patient who had a perforation, but they were not able to rescue the patient for whatever reason. It can still happen. So this is not dependent on the technology. It had to do with operators. So that's why it's still very important that despite the fact it's so safe, you want to pick an operator who does a lot of these, because there's still complications that can happen. And this is just looking at it again in a different way. Okay, next. All right, here. So that was in a paroxysmal patient cohort. The next study that was done was called Advantage AF, and this is in a persistent cohort. Now, I'm not going to talk about Advantage itself. I'm going to talk about Advantage phase 2, and this is important. So all these success rates I was telling you about were all about recurrence of atrial fibrillation, the way we used to measure it in clinical trials for AFib ablations, measuring 30-second recurrence. So if a patient had a 30-second recurrence, then that is a patient who had the recurrence, and they will go into the recurrence rate. But then we found out, as more and more studies were done, that really that 30-second recurrence rate is not meaningful to the patient. What you want to look at is the burden of atrial fibrillation, because the patients will come to us and they say, I feel a lot better. And then we say, no, we had a recurrence. It was 30 seconds on your monitor. So no, that's a recurrence. But then a group of electrophysiologists came together and we decided that actually we should go by burden. So this is why this Advantage AF phase 2 is important, because they put loop recorders in everybody. And now we can measure the burden. And then what these lines are going from the top, the yellow, then the purple, then the green, then the red and blue, is what percentage of patients are having, for example, yellow, AFib freedom from AFib for 24 hours. So 94% of those patients who had persistent AFib did not have any AFib episode lasting more than 24 hours. And then when you go down to this 30 seconds, the success rate drops to 51%. So now we're trying to find the meaningful burden. It's starting to be around 1%. So if people have on a loop recorder a 1% burden, those are the patients who would usually seek hospital care or reach out to their doctor. Anything less than that, they're usually doing very fine, and we don't have to intervene in those patients. So this is what this is about. But this is a very important development, because very soon the FDA will change the 30% recurrence rate to a burden rate. And that's going to be a very important and welcome change in the way we run our clinical trials. I have to go back. And then what about Avant-Garde? So Avant-Garde so all of these studies that I just showed you are in patients who failed medications. And then they're included in the studies for persistent AFib. Now, how about patients who haven't? So this is Avant-Garde. This is the first study that's going to randomize patients who have persistent AFib to first-line ablation versus antiarrhythmic drugs. So this is a welcome thing. I'm actually leading the study. And it basically will take patients with persistent AFib and randomize them to an antiarrhythmic drug. So they're drug naive. They're going to be randomized to an antiarrhythmic drug versus ablation with the pentaspline Farapulse system. Enrollment is complete. All of these patients will get also a loop recorder. So we're hoping to get our first report out on the study in the spring and at ACC, I'm hoping. And then that will be the 1 year outcomes. And then we'll still have, because we have loop recorders now, we will have a 3 to 5 year outcomes report out from this study. So this is a very important development, because I think we will change the guidelines. So we had previously 2 studies called Stop AF First and Early AF. Those are the ones that changed the guidelines for paroxysmal AFib. So that's why now when a patient has paroxysmal atrial fibrillation, we can go directly to ablation without having to try an antiarrhythmic drug. And those studies, Stop AF First and Early AF, both were in the New England Journal, actually in the same issue, showed that ablation is much better than antiarrhythmic drugs. And that's why now we can go to ablation directly. So I'm trying to do the same here in persistent patients in the Avant-Garde study. So in conclusion, pulse field ablation basically not well dominated, it's already dominated atrial fibrillation ablation. It's a lot faster, it's safer. You still need good operators. I think it's great for heart failure patients, again, because it's faster. So this being faster is important, especially in heart failure patients, because you don't want to spend hours doing an AFib ablation. Now we can drop it down to about 1 to 2 hours instead of 4 to 6 hours. So then your patient who has heart failure, doesn't have to be under anesthesia for that long, with all the hemodynamic changes that go along with it. And also they won't get the volume and that you want to try to avoid in these patients. And then us as operators and the patients, we won't have to worry about pulmonary vein stenosis, esophageal fistula, or phrenic nerve injury. We still need better tools for mapping, especially in patients who come back with recurrence of AFib, but now their pulmonary veins are isolated, meaning they've been ablated, they're still well ablated, durable ablation. What do you do next? So we're working on that too. There are a lot of different softwares that we're investigating to do that. And then that's the last one, is the reduce when PV remain isolated. So I think it's great. One final thing, when all this fails, so bring them back, everything fails. and they still have AFib with rapid ventricular rates. Don't forget AV node, and also device therapy works very well. So that is something that we use as a last resort almost, but I think we avoid it too much, especially at the clinic. I think I'm having a rethinking about this, that maybe we should offer it sooner than later to patients. And sometimes we do that and AFib ablation. So we preserve their atrial kick, but then when they go into AFib, they don't go too fast as much as we can. So we're also working on some thoughts on studies to address that issue. And thank you very much for your attention. I'm no longer on X, so you can forget this. Just use the link.
Thank you, Dr. Wozni. Our next speaker is Dr. Jean Bhattacharya. Dr. Bhattacharya is a heart failure cardiologist and director of the HFrEF clinic here at the Cleveland Clinic in the section of heart failure and transplant medicine. He's also the associate program director for the section's advanced heart failure fellowship program. And this morning, Dr. Bhattacharya is going to be speaking to you about cardiac contractility modulation.
Thank you so much. Appreciate the opportunity to be here. That's 2 EPs in a row, so I'm glad that someone from heart failure is talking. I need a break from catheters. I won't be talking about catheters. I will have to show you what this device looks like, though, and I apologize for that. So I think CCM is part of a growing field in heart failure. And the reason it is because the risk of heart failure is so prevalent. Almost 1 in 4 people are at risk for developing heart failure based on the Framingham and Mesa studies that we have. And the lifetime risk is growing, and half of those quarter are HFrEF. So this is a big growing population of patients that some will respond very well to GDMT, which is still the pillar of what we do. It can be initiated fast and rapidly, titrated up, and we can improve survival and symptoms. But as we know, and this I'm sure we'll see a lot during this summit, there is a portion of patients where despite being optimized on medical therapy, they cannot feel better or the best they can. They still have symptoms, still decompensation, and a few do progress to advanced heart failure. So income CCM, which has not been a new technology, this has been around almost for 20 years being studied in randomized studies and such, and coming to the forefront here where we start hearing about it more and more. But this is a device that goes in just like a pacemaker or an ICD. Here in the A screen, you see the original iteration of the device that was being implanted in patients with 3 leads, and now in B where we have it cut down to 2 leads, so less leads, less complications, things like that. And C, we see that you can actually place this along with people with defibrillators and things like that on the opposite side. And we'll go into some of the newer technologies later, but this is where we are at the moment. So how does it work? We have 2 leads currently that are placed in the RV septum about 2 centimeters apart, and it delivers a fairly high voltage, about 7.5 volts for 22 millisecond duration during the absolute refractory period of the ventricular action potential. Now here, what we see is that this device is fairly nuanced in that it will have an upper tracking rate about 110 beats per minute. So if you start seeing anything that goes rapid than that, or if something comes earlier than what is perceived to be in that 110 beats per minute mark, it will stop therapy. And this is important because for patients with HFrEF, there are risks for ventricular arrhythmias, AFib with RVR, things like that. And it's important that we are not giving inappropriate therapies at inappropriate time. So if you see here on the bottom screen underneath that initial electrocardiogram, we see that there's a PVC that comes early. The CCM is actually not giving therapy during that time, resets, and then CCM therapy does start again. On the upper right there, we see that patient is getting his therapy, or he or she is getting their therapy as regular. They start going into a ventricular arrhythmia, into VF, CCM turns off and does not deliver any more therapy. Once shock is given, sinus rhythm is restored, or AFib with a reasonable ventricular rate is restored, the CCM therapy will then reset and restart giving therapy. Does septal scar matter? I bring this up. This is a small study looking at cardiac MRI and degree of LGE in the septum. And there are some small studies looking at the degree of LGE might interfere with the benefit of therapy, but again, very small studies and still need to be in larger kind of patient populations. So how does this work? It actually works on multiple levels where we see short-term effects, intermediate, and then long-term effects that sometimes last despite turning off CCM therapy. In the short term, here we have the overall myocyte on the left-hand side. It's a very busy slide, but if we look at this and we see what CCM does, it boils down to increased intracellular calcium cycling. So you have better phosphorylation of phospholamine, upregulation of circuit 2A, and increasing contractile force. So you're not only shuttling and making the monocyte more sensitive to calcium in the cytosol, but it also cycles it out. So you can actually get better recoil and diastolic function as well. Hours to weeks, we start seeing gene upregulations of B natriuretic peptides, myosin light chains, troponin I, myosin binding protein C. We see reduction in cardiac fibrosis with increased activity of the matrix metalloproteinases and decreased cardiac fibrosis markers. And then from a vagal nerve sympathetic standpoint, we see decreased afferent vagal tone. And then in terms of the long-term effects, in HFrEF, there can be some reverse remodeling in earlier studies, improved functional status, and improved quality of life. And in HFpEF, which is now being studied in a larger trial, which we'll talk about a little bit later in the day, but there might be some signals toward improved patient quality of life, functional status, and possibly in diastology as well in some small pilot studies. So, in heart failure, we love evidence. I want to go over the evidence of where CCM has been and where it's actually going. So when we look at FIX Heart Failure 4 study, this was 164 patients that were randomized. All patients got implanted with a CCM device, and it was turned on and off at week 12. So half were turned on, half at the time of implant were turned off, and then halfway through they actually crossed over. So we see here when we look at quality of life metrics, peak VO2 and 6-minute walk test, there were sustained effects when patients were actually on the device first and then turned off halfway through, and then patients who were actually turned on and off initially had a decrease after the device actually turned off. So when we look at quality of life, initially when patients had the device turned on in the blue, we saw an improvement in their overall Minnesota questionnaires, and then slightly worsened as the device turned off, and then peak VO2 initially improved and then decreased when the actual device was turned off as well. There was a sustained effect. There was possibly a placebo effect for the patients who initially had the device turned off and then after, but they actually sustained and slightly improved their peak VO2 and 6-minute walk tests as well. So this was a big study because then it led to the FIX-HF study, which was a larger randomized control trial looking at optimal medical therapy versus optimal medical therapy in CCM device. So what they showed is that one, the median implant time was around 165 minutes. This was the initial 3-lead device that was being placed. The primary endpoint was an odd one. They looked at ventilatory anaerobic threshold, not one that we usually use in clinical trials in heart failure, but this was the endpoint that the FDA had pre-specified. And they looked at secondary endpoints such as peak VO2, Minnesota Living with Heart Failure Questionnaire scores, 6-minute walk test, and a greater than equal to 1 change in NYHA class. So we look at the top, there was no change in ventilatory anaerobic threshold, which I haven't seen any studies particularly looking at this metric in terms of changing outcomes. So again, a very weird one to pick, but I wasn't there. So peak VO2 was actually substantially better in the CCM group, where you saw an increase in peak VO2 nominal value, but in optimal medical therapy, you actually saw a decrement in peak VO2 and exercise capacity, aerobic capacity as well. When we look at their questionnaire scores, patients with CCM had an overall larger improvement in quality of life, and the NYHA was a higher increase in NYHA improvement in NYHA class in the CCM therapy device. This was a little error that they had when they actually did the study, or when they did their publication. The CCM actually had an improvement in 6-minute walk test, so they switched OMT and CCM there. They subsequently had another FIX-HF 5C study, which was actually looking instead of at VAT anaerobic threshold. They actually went and started looking at peak VO2 as their primary endpoint in 24 weeks. They looked at a control of 86, which was part of that fixed HF5 study, and then the treatment arm, which was a new kind of 74 patient arm. And they looked primarily at EFs between 25 and 45% in this patient population. So again, primary endpoint being peak VO2 and secondary endpoints, health questionnaire scores, and NYHA class. They also looked at the differences between branch points of EF, so less and greater than 35%. And what they showed is that, one, that patients had improvement in peak VO2 over the 24-week period. But when they looked a little bit deeper, they showed that this profound effect was actually more in the higher ejection fraction. So greater than 35% had more of a change in their peak VO2, improvements in their quality of life questionnaires, and a slight greater effect improvement in NYHA, as well as the 6-minute walk test. So what they found is that the effective CCM, which does have it in lower ejection fractions, but really 25 and greater, and especially above 35%, had a more improvement in their aerobic capacity and quality of life scores, which is important because it triggered their newer studies looking in the greater than 40%, the HFpEF population to 70%. They did a small study in fixed HF5C2. This was mainly looking at their newer device, which instead of having 3 leads, had 2 leads placed, a little bit simpler in terms of implantation, or at least I would assume so. But they showed that they had the same effects with no significant issues in implantation and no safety concerns with this device, which is now the one that's being implanted now. So those were the randomized trials that were done. There are some real world registry studies out of Europe. This is based off 51 centers in the European Union. And they looked at subgroups between less than 35%, 25 to 34%, and 35% and greater. They also looked at differences between normal sinus rhythm and AFib, if there was any differences between the two. Here you can see the total cohort. There was an improvement in NYHA class, Minnesota questionnaire, as well as the ejection fraction, up to about 7%. In the subgroups, we saw significant effect amongst all the ejection fractions, less than 25, 26 to 34, and greater than 35 when it comes to NYHA change. A little bit more pronounced changes in the Minnesota questionnaire score in the lower ejection fractions, and a little bit greater of an improvement in ejection fractions in the lower than 25% group. And there is no significant difference between the effect of the device in AFib or in normal sinus rhythm. When they did their initial 3-year analysis, now remember, this is a registry of all patients implanted. There's no control, so they used a MAGIC risk score to give a kind of an estimated survival curve for patients. And they showed that people in the EU registry did better than the MAGIC score, in line with patients with the Seattle heart failure score. So when they did a longer-term analysis, about 5 years, they showed that specifically in terms of survival curves, that patients with ejection fractions over 25% and especially over 35% had better expected outcomes than expected, where 25% and less were in line with what the MAGIC score risk predictor predicted. And we see here on the right-hand side where for the survival curves, the less than 25% had worse survival compared to the 25 to 34 and the greater than 35% group. So current indications, this is currently FDA approved here in the United States, also approved for implantation in Europe. The level of evidence has not yet gotten a grade in any of the heart failure guidelines, USA or in Europe, but we know that this is a potential device that we can use to help improve quality of life in patients who just not have had the initial kind of expected response to GDMT. Also in the future realm, Dr. Varma, who was pivotal in this study, looking at the combined CCM device and defibrillator. So in one device, you have a defibrillator and CCM therapy. This was just published. I believe they released at HRS, the DFT testing results, which were all 100% efficacy in DFT testing, and this study is ongoing as we speak. So this might be a newer option for patients who need non-pacing or even in the future pacing defibrillators to also get CCM therapy as well. So currently, who do I consider this patient for? Well, 25 to 45%, so not just the less than 35% group, which we think about for HFrEF, but people on max tolerated GDMT, not indicated for CRT, who are still functionally limited or having decompensations despite being on the highest doses of tolerated GDMT. I think one of the questions is obviously for the CRT group, the patients who are specifically CRT non-responders, is there a role for this type of device if patients are not responding to CRT or have an adverse effect to CRT? But I think that needs to be borne out a little bit more in discussion and research. So again, GDMT is the foundation for heart failure, but this expanding therapies in the C entering stage D heart failure patient population, we're still symptomatic. This is a wide realm. CCM provides a potential benefit for patients, especially when we talk about improving functional capacity, aerobic capacity, and I think the future directions in HFrEF and HFpEF in this device are pretty wide. Thank you.
Thank you, Dr. Bhattacharya. And speaking of ICDs, that's a great segue into our next talk. This is by Dr. Santangeli. He's the Associate Section Head and Director of the VT program at the Cleveland Clinic. And today his presentation will be on ventricular tachycardia and arrhythmias in patients with heart failure reduced ejection fraction.
Thank you very much. Thank you, Dr. West, for the kind invite to this symposium. Really, we all know that VT is a huge problem in patients with HFrEF. This was actually old data, I can't believe from back 2017, seems like yesterday. When we look at the prevalence of VT in clinically significant VT in patients with HFrEF, has been reported up to 40%, which is fairly high. And it does impact the outcomes in these patients. And I'll show you later how and why. But of course, HFrEF is almost the perfect milieu for VT because of fibrosis, because of remodeling, which is not just anatomical, it's also electrical. And of course, when VT happens, then the perfect storm happens in these patients. There is some data that can cause desynchrony. There is some evidence that can cause mechanical and bioenergetic uncoupling, can change the metabolic adaptation of the heart, and in general can cause adverse mortality in these patients. And of course, this can lead to adverse remodeling, hemodynamic decompensation, and other downstream effects that can progress the heart failure condition and lead to eventually mortality. So it is a problem. Now, in terms of treatment, though, it's really, we don't have a lot of options here. This is a meta-analysis from 8 randomized controlled trials. And this is actually focused on patients with reduced ejection fraction. The only drug that actually works is amiodarone, really. If you look at Sodalo, which is not a great drug anyways, negative inotrope, really neutral effect. Azimolide, Solivarone, they don't even like commercial available, but also neutral effect. And I didn't put here mexiletine because most of the times, as we all know, mexiletine is more of a cry for help than actually a real drug. It doesn't do really anything, and it's never been shown to be beneficial in any subgroup. The other problem with amiodarone is that, of course, specifically in the HFrEF population, the strongest data come from the subgroup analysis of the SCEDEFT. But if you put all the randomized control trials together, we know that amiodarone can actually increase mortality in these patients for a variety of mechanisms, end organ toxicity being the most common one, but also some other mechanisms that we still don't fully understand. And there is a wealth of literature increasing. Also, when amiodarone is used, for example, for atrial fibrillation in HFrEF, can potentially cause an increase in mortality. Now, when we use antiarrhythmic drugs, the other problem that you will see is the hemodynamic effects of antiarrhythmic drugs. Of course, class 1A agents are really not used, but most of these drugs, if you look at the right side here, they're mostly negative inotropes, which is a huge problem for patients with HFrEF, and that's why we really don't like to use pretty much any of them. So these patients really can be treated mostly or only with amiodarone, which with limited efficacy, some efficacy, but limited efficacy. So therefore, what is the next step when drug fails? And we haven't really done any studies of first-line therapy quite yet, I think because ablation for VT is still relatively high risk compared to atrial fibrillation ablation. But here, if you look at whenever antiarrhythmic fails, then ablation can give you at least 20 to 40% increase relative risk benefit in some ways in terms of VT-free survival, which is significant. And of course, this is from the randomized control trials. But when you deal with these patients, and that's something that I strongly believe in, and I'm very grateful to be in this conference and to see a lot of my colleagues here, because part of the outcomes for these patients are very important, very related to the fact that EP has to work in collaboration with other sections, heart failure being one of the sections that we have to work with, but together, of course, with cardiac surgery and imaging. And here, at the Cleveland Clinic, we have a multidisciplinary approach for all of these patients. There is no star on this team. It's a team sport, really. And expertise in VT ablation has to be there, of course, but in addition to that, you have to be an expert in advanced heart failure. You have to make the right decisions at the right time for mechanical hemodynamic support devices, and also have to understand if patients may have an exit plan. And of course, these are collegial type of decisions. And most of the times we manage this with multidisciplinary, sometimes meetings that we have for complex patients. We personally meet every Monday at 5 p.m. to discuss our inpatient VTs in terms of what the plan would be, and we involve our colleagues as necessary. So you will see these patients as you, of course, run in heart failure. Acutely, what can you do? First of all, the very first thing to do is to interrogate the ICD and reprogram the ICD. This can reduce the burden of ICD shocks. It is safe consider also increase the detection duration, especially if the VT is hemodynamically stable. You have to favor ATP interventions. If stable, you can also consider to turn off ICD therapies. It can be very painful for patients. Think about typical patients, patients with LVAD and VT storm, for example. In CRT patients, you can consider reprogramming the pacing wavefront, because we know that VT induction is also depending on which way you're pacing the ventricle. You can go in short term for RV only, of course, not ideal from a hemodynamic perspective, or LV only pacing. And then, of course, identify and correct the triggers. We all know that. And then sedation and mechanical ventilation, where it's important to treat sympathetic overactivity. If that's a trigger, sometimes we consider temporary sympathetic denervation in these patients. Of course, we use short-acting analgesics and benzodiazepines, and then medical therapy. Beta blockers, as possible. Some of these patients cannot really tolerate it. Class 3, typically, again, amiodarone, sodal, or not a strong evidence, and of course, IV lidocaine. All right, but then the other aspect is how we do these procedures. And that's something that I want to put there because most of the times when we go for a procedure, you have to realize that we do not have to induce VT or even CVT during the procedure. Now, of course, when your patient has hemodynamically stable VT, this is a case where large inferior infarct, you can see, there is a VT 150 beats per minute. We can spend the time that we want to define the critical sites for VT interruption in ongoing VT. However, all these sites are within the scar that is being pre-identified with either MRI, CT, or echocardiograms. So the idea is that if you keep the patient in sinus rhythm and adjust ablate the scar without even inducing VT, you'll be able to get the same job done. And I'll show you later here, because the problem here is that whenever you do induce VT, and that's the way I was trained, we used to induce VT number 1, go after it, then induce VT number 2, go after it, 3, 4, 5, 6, 7. And at the end, you have no VT, but sometimes you don't have the patient either at the end, because you can end up having decompensation and high mortality risk at 30 days. So we changed our approach completely. Here, in particular, we use a specific one, which I'm going to show you later, because I've been interested over the years to understand why patients decompensate during a procedure. You see that most patients here present with at least one unmappable VT because of hemodynamic deterioration. So that's a problem for us. And if you look at the risk factors for decompensation, we came up with this score. It's called the Payne's D score. Some of them are modifiable. For example, if you do use general anesthesia, of course, you make most VTs that are hemodynamically stable unstable because of the effect of the anesthesia. But some others, pulmonary disease, advanced age, low EF, NYHA class, we cannot really modify before the procedure. And if you put all these factors together and you have a Payne's D score greater than 17, you have a 20 to 25% risk of hemodynamic decompensation during the procedure, which is significant. So how do we change the approach here and with the approach that we use these days at the Cleveland Clinic? So if we can keep the patient in normal sinus rhythm with sedation or antiarrhythmic drugs, sometimes we use them during the procedure to keep the patient in sinus rhythm, can just target the abnormal substrate. How do we define that? We just look at the MRI, CT, or echo. We know where the scar is. We go for the whole ablation of the scar in sinus rhythm. It's a fairly surgical approach, not much EP involved, but we know that VT comes from the scar, and therefore we go for it. We have minimal to no VT induction. Typically, we do one induction only of VT to verify that the VT is compatible with the area of scar. So therefore, in order to have VT in humans, you need to have slow conduction. That's number one requirement for reentry. Probably we learned that from back in med school. So therefore, if you do see slow conduction in normal rhythm, those are the same sites where VT will utilize to create the reentry. So you can localize, you can calculate the conduction velocity. I'll show you some examples later. But essentially, we create a map in normal rhythm, and we calculate the conduction velocity in areas of the scar. The areas of slow conduction, we go for them. And of course, and after that, typically VT becomes non-inducible without even inducing VT. Mapping can be done, but typically is limited to an induction of 30 to 60 seconds. And blood pressure, typically before this, we coordinate with anesthesia to increase the blood pressure temporarily, usually to a map greater than 80. We do a quick induction to verify that the VT is coming from there. We cardiovert after 30 to 60 seconds. This is just an example, one of the many patients that we see that all look the same to me. I mean, I also see you as here we have a 72-year-old male with non-ischemic cardiomyopathy, ejection fraction of 10%. 2/3 of the procedures that we do here are failed VT ablation somewhere else or referred from other EPs. And medium ejection fraction for HFrEF is way below the 30% range. I think last time we calculated it was 22 to 25%, but it's just an example. Here you can see the RV doesn't look too bad. Of course, is a very typical non-ischemic cardiomyopathy type of look on the echocardiogram. And in non-ischemic cardiomyopathy, it's very crucial to do imaging before the procedure because really wall thinning and wall motion abnormalities on echo do not really correlate very well with the abnormal substrate. That's why we push always to get some imaging beforehand. And ideally, I would encourage everybody to get imaging at the time of ICD implant, right before the ICD goes in. If you refer a patient from primary prevention ICD implantation, just get an MRI because years down the line, they may need a VT ablation and we have a clear picture of where the problem is already. Here, that's what we see in the EP lab. Here we are epicardial, we're mapping the outside surface of the heart. On the right side, everything that you see in red is low voltage. Just like a 12-lead EKG, when you see low voltage, like with amyloid, that means scar. Everything that is in red is all scar. Now, of course, we cannot ablate the full ventricle because in this case, of course, the whole ventricle is scar. So what we do, we look at conduction velocity, which is on the left side, and it's color-coded. I don't know if you can see these vectors moving, but essentially here, these areas, let me move on here. I think I put some, here, perfect. Those areas there of blue is where there is slow conduction in normal sinus rhythm. Therefore, when you have slow conduction in sinus rhythm, you will have slow conduction in VT. And what we do, how do we prove that? We position our catheter there, and we do a single induction here to prove that the VT is essentially coming from there. How do we know that? We have VT going on, and the catheter in green here, you see there is some electrograms. I don't know if you can appreciate from here. That are in between the QRSs. Essentially, we do a quick induction. We prove that the slow conduction areas is responsible for the VT, and the cardioversion happens after 30 seconds. When I was in training, we used to keep patients in VT for minutes, which is really a problem. And in this case, of course, you have absolutely no blood pressure, but we can verify that it's coming from there, and we do the rest of the procedure in normal sinus rhythm. By doing that, we have been essentially reduced our use of hemodynamic support device. Over the last year, probably used 3 cases only, despite increasing in volume, about 20% every year consistently, and increasing in complexity, of course. But whenever patient is in incessant VT, so we cannot keep them in sinus rhythm or high burden of VT, that's why hemodynamic support is actually very important because I cannot work in sinus rhythm. So I'm forced to be in VT. And this is just one of the examples where we put an Impella 5.5, which is our go-to typically type of support devices for these patients. Now, how does that work? So the number one message I want to give is that hemodynamic support devices work only if it's done preemptively, before the decompensation. If you use it as a bailout approach, the mortality rate is extremely high. In this old series, when I was back at Penn, it was about 80% of patients died within 30 days. So if you have to use a support device, use it, of course, preemptively. We have some data also from my prior experience that it does reduce the risk of decompensation during the procedure and may have a benefit, not so much in terms of VT recurrence, but in terms of death and transplant in patients with very low ejection fraction and high PNSD score, so high risk of decompensation. So I showed you that we change our approach. We don't induce VT. Actually, we try to stay away from VT induction in patients with VT. We ablate the scar, we ablate the slow conduction in sinus rhythm, and we sometimes don't even do any induction. By doing that, these are the data that we have, the most recent one. IVTCC was the largest registry in the United States, 12 institutions. I participated to it when I was back at Penn, 2,061 patients, 12 high-volume VT institutions. And these are our CLEAR VT, which is Cleveland Clinic VT registry. We call it CLEAR VT 2023-2024 data, 513 patients. Periprocedural complications have dropped from the benchmark of 7% down to less than 3%, about 2.5%, but at 30-day mortality, we're way below the benchmark from 5% to 2%. And I have to be really grateful to all my heart failure colleagues for keeping all these patients alive, actually, after we do our procedure. So thank you for that. Now, this actually was interesting for me. And recently we looked at another aspect, procedural volume, specifically in patients with HFrEF and complications. This is a paper that just came out on Jackie P. And the idea behind this paper is that we look at our data. We did 513 patients in about 1.5 years. So is this something that is also true nationwide? In other words, the hospitals that do higher volume of VT have lower complications. The first thing here is that if you look at nationwide, high volume is actually more than 50 a year. So it's really not that high, but I mean, that's what most institutions do. And low volume is less than 10 a year. But if you look at that, there is a gradual increase in hospital mortality, cardiac tamponade, and major bleeding events for patients that go for ablation in low volume centers compared to high volume centers, despite the fact that in this paper, if you go and look at the tables, patients were sicker in high volume centers. So we calculated that all it takes is to shift 17 patients from low volume to high volume to prevent one death, one tamponade, and one bleeding event. I think it's a significant finding. And the reason why that happens is not so much because better EPs, but I think it's just like a better environment where you have a better heart failure group, better imaging, and a multidisciplinary team that takes care of these complex patients. I'm going to stop here and open this for questions. Thank you.
Thank you, Dr. Santangeli. Our last speaker today is Dr. Niraj Varma. Dr. Varma is the staff physician in the section of electrophysiology and pacing here at Cleveland Clinic. He's published many articles in electrophysiology, and he's the author of a textbook on electrocardiography, as well as numerous chapters in other textbooks. Dr. Varma's topic this morning is the future of remote heart failure and EP monitoring.
Thank you very much, Dr. Best. Thanks for the invitation. Ladies and gentlemen, good morning. So monitoring is a vital part of EP practice and gradually more and more in heart failure management. And why do I say this? Well, the 2023 recommendations for remote monitoring in the EP world assigned a Class 1A recommendation, really endorsing the recommendations from 10 years ago. So this is a vital part of EP practice. And the reason is it improves patient outcomes and it improves hospital workflows. So because remote monitoring versus routine clinic appointments provides an advantage, and you see here, when you have continuous monitoring with an implantable device, it relays information that is analyzed and then presented. It is filtered and then presented at the hospital for the clinician to review. And of course, when you have this kind of implantable monitoring, you have early detection. And in the bottom right, you see in blue, you can detect early significant events, even if they're clinically asymptomatic silent events. Compared to conventional care, you have an advantage of over 3 or 4 months sometimes. So that leads to the possibility of preemptive therapy. And first of all, we examine this for device functions. So here I show lead fracture, ATP for AF, inducing VT, these kinds of events. But if you acted on those data, you could reduce the number of patients with inappropriate shocks and reduce the number of related hospitalizations. So for the first time, we saw that management dictated by remote monitoring, enabled by remote monitoring. So remote monitoring is not a therapy, but when you use this for guidance, you improve patient condition and you reduce hospitalizations. And by the same token, when you have this, you can manage a group of patients in the community, a group of patients that come for ambulatory care, monitor them continuously, but only bring in the patients as and when they need to be seen, and sometimes preemptively. So in this initial TRUST trial, we showed that you reduced outpatient workflow by 50%. So you improved patient condition and reduced outpatient workflow. So this is well established in EP practice. So the question is, can we extend this to management of heart failure patients? And here the data are developing. They are less mature just now, but the possibilities exist. We saw this curve earlier where you have episodic decompensations in heart failure, and each one is associated with a poorer prognosis. So we want to preempt them. Can we do that? Well, we should be able to, because in the bottom inset, you see that prior to any decompensation, maybe 3 or 4 weeks prior to any decompensation, when the patient is still asymptomatic, there are significant changes, particularly in hemodynamics, filling pressures, autonomic auto-adaptation, interthoracic impedance, and then finally, the patient presents with an acute decompensated episode. So can we preempt this in the same fashion as we did with device monitoring data? So the answer is yes. I mean, when we did direct hemodynamic monitoring, and this is the laptop study from over 10 years ago, and this involved attaching a left atrial pressure sensor to the interatrial septum to provide continuous hemodynamic monitoring. This showed that we could stabilize left atrial pressure, use preemptive therapies with diuretics, and also improve GDMT and stabilize the patient. So this showed that we could preempt acute heart failure admissions. So very, very important. But this is an involved implantable technology. It's a complicated device, and it is not generalizable. Can we be less invasive? Well, this is still invasive. This is a pulmonary artery pressure sensor. This is the CardioMEM study. And this shows that when you use data coming from a pulmonary artery pressure sensor, that treatment groups have reduced heart failure hospitalizations and a tendency to improved survival. And I show these data here from a sub-study of Champions. These are the patients who had CRT. And in fact, I mean, Champion was run about 15 years ago. These patients had a cardiac index of 1.8. Now they would be qualified for LVAD therapy. Nevertheless, in this group of patients, survival tended to improve and heart failure hospitalizations reduced. So this is from the CardioMEM study. Still implantable. So can we move to non-implantable information? Can we move to information from implantable devices without additional implantable hardware? So devices, implantable devices, pacemakers, ICDs, CRTs, now convey a lot of information apart from device activity. Information that might be important for heart failure hospitalization. So heart rate variability, ATAF burden, effective biventricular pacing, activity, thoracic impedance, heart size, respiratory rate, sleep incline, weight. All of these things can be conveyed via standard implantable device without adding a direct hemodynamic sensor. So let's look at the interrogation of a standard CRT device. And this is a patient who presented with acute decompensated heart failure. That's the big blue arrow at the bottom right. But you see events started happening 3 months ahead of time. You see atrial fibrillation starting, increased ventricular rates, drop in CRT pacing, drop in physical activity, all before he presented in congestive heart failure. And you see thoracic impedance at the bottom increase. So if we tracked these parameters, could we act preemptively if we track them with remote monitoring and prevent heart failure hospitalization? So in fact, Optival has been the most examined in multiple trials. So a single parameter was examined, randomized controlled trials, but they were ineffective. You see this, looking at Optival, no change in all-cause death or cardiovascular hospitalization. So disappointing. Perhaps we should use all of those parameters together, or several of them, as many as you can manage. And the data from that were very impressive. This is the InTime trial, randomized controlled study, without Optival, without thoracic impedance, but using 7 other parameters. And we found that in the top, which are the remotely monitored patients, survival improved. Not only heart failure hospitalizations, but survival improved. And this was done with a central monitoring unit where those data were manually, a lot of data were manually adjudicated every day. So this is very work intensive, and you can do it as part of a trial, but not part of general hospital workflow systems. So can you embed algorithms that do this work for you? So probably the most well-examined one is the heart logic. This uses 5 parameters, including heart sounds. And they found that the default threshold was often reached 6 weeks prior to a heart failure event. So you have enough lead time for preemptive therapy. This algorithm can be patient optimized, so patient individualized, and it compares daily measurements compared to a reference calculated over the prior 3 months. So this changes every 3 months. Found that the prediction for heart failure hospitalization had a sensitivity of 70% and a specificity of 86%. These are good, but probably not good enough because the false positive rate was 1.56 per patient year. That's a lot of extra work to manage. And often these were unexplained. Most of them were unexplained. So there's a lot of nonsensical information that is delivered to the clinic and that it creates an increased work burden. So this still needs refinement. The precision is not as good as it should be. And each company has its own particular algorithm. Heart Insight, again, 7 parameters, lower false alert rate, but still significant, and sensitivity for predicting heart failure hospitalization, 66%. And then another proprietary one probably has even less efficacy. So this is work still to be developed. We can move to insertable cardiac monitors, but one of the difficulties of all the algorithms that I've shown you earlier has been that they've been restricted to patients with ICDs and CRTs. So patients with HFrEF. What about patients with HFpEF? Or patients with general pacemakers and moderately reduced EF? What can we do? There's very little information out there, but there is a movement towards using insertable cardiac monitors, which can track a surprisingly wide range of parameters here. So ILRs to monitor and predict heart failure. In this first study, which is very, very rigorously done, 20% of monthly evaluations were deemed at high risk using the parameters that they show. And you see the risk score in the graph on the right. 7% were followed by heart failure hospitalization or outpatient diuretic in the next 30 days. Only 7%. So this, again, results in a very high alert burden, a very high proportion of false positives. So again, probably not prime time yet. AI. Of course, AI may resolve a lot of these problems, promises to at least. So this is one algorithm, which is non-manufacturer based. So this is manufacturer agnostic. You can apply it across all ICDs and CRTs and pacemakers. So it has promises for the HFpEF population. So this is the Signal HF predictive AI algorithm, FDA approved. And you see on the bottom left, it looks at several parameters and assigns a weight to them. And when that crosses a particular threshold, it delivers an alert. And the risk estimation of patient heart failure within the next 30 days is significantly improved compared to the manufacturer-based algorithms that I showed you earlier. So there's promise here. FDA-approved AI algorithm using data from all implantable devices, ICDs, CRTs, and pacemakers, so HFrEF and HFpEF patients, to reduce heart failure hospitalization. So that is the promise, and this is under evaluation. Of course, now we live in the world of wearables. We're not restricted to implantable devices for information. Watches and rings collect a variety of information. There's data to show that changes in voice quality with pulmonary edema can predict heart failure. Textile integrated sensors, and significant data from wearable patches that patients can wear for several weeks, if not months, conveying significant information similar to what I showed you with the ILR, and that might predict heart failure hospitalization. Again, what we worry about is the false positive rate, because these are algorithms that are not completely refined and they generate unnecessary workflow. I want to go back to this presentation of a patient with heart failure and emphasize that events start occurring several weeks, if not months beforehand. This is persistent atrial fibrillation, which happens very often in heart failure patients. Amongst patients with implantable devices and heart failure, AF is the most common alert that is delivered in 30 to 40% of patients. So this is very significant. It's an acute or subacute trigger of a decompensation. And then emphasizing the data that Dr. Wozni showed earlier. This is from the CASTLE-HF study. Intervention with an ablation in a heart failure group of patients significantly improved survival and reduced heart failure hospitalization. So ablation, early ablation can be empowered by remote monitoring data and then improve patient outcomes significantly. And again, what happens if you can't reduce AF burden significantly? Ablation has been shown to be very effective in this trial, but some individuals may not have improved outcomes there. AV nodal ablation and pacemaker also has a survival benefit. So this is from the HFrEF study. This is a mortality trial, randomized trial. And interestingly, it only required 200 patients to demonstrate a survival benefit, showing the strength of rate control in these patients. So AV nodal ablation amongst patients with atrial fibrillation, recalcitrant to ablation therapy or drug therapy, AV nodal ablation, and in this case, CRT implant, improved survival. So AF control in the heart failure population is incredibly important for heart failure control. So in summary, I would say that implantable hemodynamic monitors have been shown to be very effective, but they're not generalizable. When using surrogate parameters of hemodynamic compromise, the predictive ability of heart failure events with patients with implantable devices is modest. Indeterminate alerts generate increased patient contact and work burden for us. Prediction of heart failure events in patients without CRT or ICD is nascent, so in the HFpEF population. Promising developments, but nevertheless, nothing very mature there. Treatment at a preclinical stage is still rudimentary. By that, I mean preemptive therapy. Before the patient has symptoms, before his weight goes up, can we act on information that, decompensation occurs 2 or 3 weeks before an acute presentation? Can we act on that preemptively? Alert-based management remains limited. However, it is important to treat precipitating events. Ablation for atrial fibrillation, either PVI or AV nodal ablation and implant, address loss of CRT pacing percentage, and several of these events that come under the EP platform. So as a result, the 2023 recommendations gave a 2A recommendation to monitor heart failure diagnostics. So this is important, but still work in progress. Thank you very much.
Okay, and now we have some time for questions. First of all, any questions from the audience here? If not, maybe I'll start a question then. So sometimes we see patients who are otherwise young, healthy. They come into the hospital with rapid atrial fibrillation and decompensated heart failure, reduced ejection fraction. And then we presume that they may have tachycardia-mediated cardiomyopathy. But what is the yield and value of genetic testing in these patients in case that may cover some underlying cardiomyopathy that may be genetically mediated?
Great question. So it's always important. Patients need a diagnosis. And if they have atrial fibrillation with rapid ventricular response, tachy-mediated, and if it's not a typical AV-NRT that you're like, oh, okay, this just needs to be ablated. But if this is truly tachy-mediated, oftentimes patients do have an underlying genetic component, a genetic cardiomyopathy. And so You still treat them, you still get them out of AFib, we still look for hyperthyroidism, but patients need a diagnosis, and we still characterize the myocardial substrate. So I loved your point about getting a cardiac MRI to understand what's going on in the myocardial substrate as well. So Titan cardiomyopathy, we're learning, right? 20% of patients present with AFib, with RVR, maybe actually Titan mutations. And so the role of genetic testing, I think, is becoming broader. So that is a patient that I would absolutely do genetic testing on.
So I have a question.
Just a comment on that. There was a study called the CAMERA study, also published in JACC. So it doesn't have to be also tachycardia-induced cardiomyopathy. A patient may come with AFib and controlled ventricular rates, and now their ejection fraction is low. And this is the first time that we know that the ejection fraction is low. So still in those, I would get a genetic testing sooner than later. But also, it's in CAMERA, they showed that even if the AFib is rate controlled, if you get them back to normal rhythm and maintain normal rhythm, the ejection fraction can improve, especially if on MRI there is no late gadolinium enhancement. So that's why also an MRI is important in these cases too. And even if the ventricular rate is controlled in AFib.
Especially when you get them, or you control their rates, or you get them back in sinus, and then they've got, an abnormal ECG at baseline too, right? That should tip your antenna up as well.
So actually, another question for you, Dr. Wilcox. So I was fascinated by your case studies. When patients with a genetic lesion come with VT, then the decision to implant an ICD is more straightforward. What happens if they come with a genetic cardiomyopathy? And the question is regarding prophylactic ICD implantation. I mean, the recent guidelines have said LMNA to extend the EF cutoff to 45%, and that's a 2A recommendation, I think, and there's also for LV and C. But for other genetic cardiomyopathies, we don't know. So how would you stratify that? Does your genetic testing yield a score sheet? Can you weight each of those genetic lesions and say, okay, above a score of X, yes, the patient needs a prophylactic ICD?
So I'm glad you mentioned the new guidelines that were recently published. And so between an EF of 35 and 45%, if a patient has a particularly high risk mutation, lamin is sort of, like most people know about lamin now. But when we think about filamin C, phospholambin, other, desmoplakin mutations, that's a shared decision-making conversation with patients. And usually these patients are young, otherwise, very viable. And so I will look at their mutation in ClinVar, we'll sort of understand the rhythmogenicity of their mutation. But if it's one of those mutations, that's pretty straightforward. It's usually associated by some evidence of a scar on their cardiac MRI as well, because they have a worse prognosis overall, and that correlates with scar. If it's a there's maybe no scar on the MRI. In fact, I just saw a patient yesterday. He's a lamin patient. His ejection fraction is 48%. And he has a particular mutation that's a Dutch founder mutation. And his mother happens to be alive and well and has the mutation, and she's 98 years old. So we sort of know how that mutation presents in that family. So instead of putting an ICD in him, his MRI has RV insertion scar. We elected to do a loop recorder. And because he really that was our shared decision-making conversation. So I think it involves a bit of investigation, which is the fun part.
Looks like we have an online question here stating, regarding heart failure alerts, what is the most common reason to have a false positive? And is there a parameter that helps identify this, or the only way is by contacting the patient?
So the commonest alerts that occur in patients with implantable devices is actually atrial fibrillation. That is the commonest alert. The thoracic impedance crossings are relatively common, but they're very non-specific. So these are the commonest alerts that occur. When we look at the algorithms that deliver a synthesized weighted score and then alert, the unexplained alert rate is very high. And by definition, it's unexplained. So we don't know what's causing that. So it's simply a false positive generated by that algorithm. And this is the area that needs to be addressed before we can use these algorithms effectively. So the answer to the question is, we don't actually know what generates the false positive alerts.
Dr. Santangeli, your great talk on VT and kind of where the field has evolved to. How do you approach the patients who are either with VT going for durable mechanical support LVAD and then post LVAD having VT and things?
So this is a work in progress. We're actually looking now at outcomes of LVAD in patients that have like early VT, let's say within 90 days from the LVAD, using the National In-Sample database, because I am not entirely sure that these patients do any worse than the ones that never had VT before, but we don't know yet. So having said that, the only spot where we cannot go to after an LVAD is the epicardium. So really, our approach typically now, when we have a patient with active VT, which is defined anywhere between less than 30 days from the LVAD implantation, we try to go in and map and ablate the epicardial space only. And because also, if you do endoepicardial, it will prolong significantly the surgery. So if you just do epicardial ablation, then you put the LVAD in. If a patient has VT again, we can go back to the endocardium, usually with a transeptal approach, actually always with a transeptal approach, and do whatever is left on the endocardium. That's the current approach here. But the number of patients is fairly small, actually. And it seems to be a difference in terms of VT recurrence between HeartMate 2 and 3. In other words, in the old days, we said, if you have VT before, you go for HeartMate 2, you continue to have VT afterwards. That's not entirely true. We saw actually a reduction of VT burden after HeartMate 3, and you guys probably know better why, the mechanism, but we're seeing that consistently now in our population here, and we have an abstract AHA from last year, actually, that show that.
Thank you, everybody, for all the great talks, panelists. Appreciate it.
Wonderful. Thank you ever so much. 2 amazing sessions this morning. Really appreciate all our wonderful speakers and moderators. Thank you.